Lichen planus is a relatively uncommon chronic inflammatory condition that affects the skin, mucous membranes, hair, and nails. It is believed to be an autoimmune-mediated disorder involving T-cell-driven destruction of basal keratinocytes, although the precise cause is often idiopathic. It may also be triggered by medications, infections such as hepatitis C, or contact allergens. While it can occur at any age, it is most commonly diagnosed in middle-aged adults, with a slight female predominance. The hallmark of lichen planus is the presence of pruritic purple, polygonal, planar papules, a classic 5 Ps description often emphasized on board exams. These lesions typically appear on the flexor surfaces of the wrists, forearms, ankles, and lower back. The papules are flat-topped, violaceous in color, and may feature a characteristic fine white lacy pattern on their surface called Wickham stria. This pattern is also frequently seen on mucosal involvement, particularly on buccal mucosa, where it may appear as a reticulated white network. Oral lichen planus is often asymptomatic, but may cause burning or sensitivity, especially when erosive or ulcerative. Lichen planus may also present with scalp involvement, called lichen planopilaris, which can lead to permanent scarring, alopecia, if not recognized and treated early. Nail changes including longitudinal ridging, splitting, and nail plate thinning or destruction may also be seen. The Kobner phenomenon, which is the development of lesions at sites of trauma, is common and may help support the diagnosis. Diagnosis is primarily clinical, especially when the characteristic skin lesions and distribution are present. However, in cases that are atypical or resistant to therapy, a skin biopsy can confirm the diagnosis and rule out other dermatosis. In patients with mucosal or widespread disease, testing for hepatitis C should be considered, as there is a known association. Additional considerations include reviewing medication history for potential triggers, such as NSAIDs, beta blockers, ACE inhibitors, thiazide diuretics, antimalarials, and certain antiretrovirals, which may induce a drug eruption that can mimic idiopathic lichen planus. Treatment depends on the severity and location of the disease. For limited cutaneous involvement, topical corticosteroids, especially high-potency agents, are the first-line treatment and are often sufficient. Occlusive dressings may enhance absorption. For symptomatic relief of pruritus, antihistamines may be added. In cases of mucosal involvement or widespread disease, oral corticosteroids, topical calcineurin inhibitors such as tacrolimus, or systemic immunosuppressants such as methotrexate, cyclosporin, or mycophenolate may be required. Phototherapy with narrowband UVB or PUVA can also be effective in generalized cutaneous disease. Most cases of lichen planus are self-limited and resolve within 1 to 2 years, but recurrence is common. Importantly, oral lichen planus, especially the erosive type, carries a small risk of transformation into oral squamous cell carcinoma, and patients should be monitored for persistent ulcerations, induration, or dysplasia requiring biopsy. For this reason, long-term follow-up may be appropriate in patients with chronic mucosal involvement. For the FNP board exam, test takers should remember the 5 Ps and the presence of Wickham stria as hallmark findings. Questions may also reference the Kobner phenomenon, pruritic lesions on flexor surfaces, and potential medication associations. Oral or genital lesions with burning or pain may point toward mucosal lichen planus, while scalp or nail involvement suggests more severe systemic disease.